Dorene Rentz will be our next speaker. She is a clinical neuropsychologist with dual appointments in the departments of neurology at Brigham Women's Hospital and Massachusetts General Hospital, and is an associate professor of neurology at Harvard Medical School. She serves as the co-director for the Center for Alzheimer's Research and Treatment, the director of outreach care for the Massachusetts Alzheimer's Disease Research Center, and clinical core leader of the Harvard Aging Brain Study. She is leader in cognitive outdoor assessments too. Yes, a little bit of my dementia there, sorry. Please welcome Dr. Rentz.
Thank you, Tammy. Good morning, everybody. Hey, that's it. You guys are awake. I want to just thank the organizers, particularly Lenore, for asking me to come and present today, because I really believe that the work you folks do is extremely important if we're going to find a treatment for Alzheimer's disease. I don't need to tell this crowd that we have had 13 failed trials in Alzheimer's disease, particularly in mild to moderate stages of the disease, and we're desperate to find a cure. So I appreciated Dr. O'Neill's comments that there are many reasons why drug trials fail, and I'm sure that some of that will be discussed later on today in the talks that I'm going to be doing. So thank you very much for all the hard work that you do, because it's really important. There's probably not anybody in this room who has not been affected by Alzheimer's disease. Is that true? Who has known someone with Alzheimer's disease? Yeah. So I don't really need to describe for you the clinical devastation that this disease has. But what I do want to say, let me see if I can advance the slides here. Is this on? There we go. But what I can tell you is that not everybody gets Alzheimer's disease, that more and more people are living vibrant lives into old age. But who are these people that are not affected by disease? Why am I having trouble? There we go. Oh.
Now we're going faster.
Can we go back one? Where do I point this? There we go. You know, Dr. Claudia Kawas, a good friend of mine, studies people who live to the age of 90 and above. So it's called the Over 90 study. Some of you might have seen her on 60 Minutes. These people signed up in a place that used to be called Leisure Village and now is called Laguna Beach. And everybody in this village actually signs up to get cognitive testing, MRI scans, and they donate their brain at the time of death. And so what she found in this study, which I'm very grateful for, is that those who drank moderate amounts of alcohol and coffee and were more overweight in their 70s tended to live it into their hundreds preserved. So that's me. I'm so glad about that. But the caveat, though, is that these people also stopped smoking. They ate plant-based diets, which is not me. I love red meat. And that means your Mediterranean diet or those that have a lot of good leafy green vegetables. And they kept up a constant low level of exercise. And another important feature of these people is that they had good family and social support. And we'll be talking more about the preventative mechanisms of these non-pharmacological treatments for brain health. But we also know, and I started collecting this slide at about the year 2000, and the pictures have changed, But we know that Alzheimer's disease is no respecter of persons. It doesn't matter who you were, what you've done, how much money you made in life, or how little money you made in life, or what you've contributed to society, that Alzheimer's disease can affect you. And I was always amazed at some of the people in these photographs who have lived with, suffered, and died with Alzheimer's disease. We all know about Ronald Reagan, but I didn't know about Henry Ford or Winston Churchill. And then some of them are even more modern people, Norman Rockwell, Perry Como. He was a favorite of ours in the 60s. I'm sure half the room here have never heard of him, but he was a great singer. Okay, good, thank you. But we also know that because of this, we are desperate to find a cure for this disease. And you know, Alzheimer's disease doesn't really affect you until it does. This is my mother-in-law, Sheila. She had Alzheimer's disease. She lived with us for 3 years before her death. That's my husband, Ray, dancing with her at our wedding. He has early signs of Alzheimer's disease now, but he's in a prevention trial. And what we are desperate for, including myself, is to find a cure. Why am I pointing to the wrong thing, I have to say? Can you do it? There it is. Before it affects my grandkids. That's Connor, that's Haley. We're desperate to actually find a cure for this disease. So next slide. And where does the story start? It starts with Alois Alzheimer, who was introduced to Augusta Dierter at a psychiatric institute in Frankfurt in 1901. And he met Augusta Dierter because she began having behavioral symptoms that were not characteristic of people with psychiatric disease, and she also was experiencing some memory loss. So he followed her until the time of her death in 1906. And he then developed some new staining techniques, believe it or not, that are still used in pathology today to see the underlying changes in the brain associated with this disease. Now, this is one of the first times that pathology and clinical symptoms actually came together. And what we know is that the hallmarks of this disease are amyloid plaques and neurofibrillary tangles. There's also changes in glia. There's probably also some inflammation. But the main features of this disease are called plaques and tangles. Next slide. And more recently, since this is a talk on recent developments, is that in 2004, that's Chet Mathis and Bill Klunk. I always put the pictures of the people who do the work on my slides because I want you to know there are real people working on this. They were the first to develop a radio tracer used with positron emission tomography or a PET scan to look at amyloid in the brain. So prior to that, in order to diagnose Alzheimer's disease, you had to look under the microscope in the same way that Alois Alzheimer looked under the microscope and used the same staining techniques. So the diagnosis that we made clinically was always a possible diagnosis because until you had pathological confirmation, you couldn't diagnose the disease. Well, in 2004, that has revolutionized our study of Alzheimer's disease with having a radioisotope that attaches to one of the players in the game, amyloid, as in vivo, as people are still alive. Next slide. And so in some of the work that I've done in the Harvard Aging Brain Study with Dr. Keith Johnson, who's the chief of radiology and our PET lab, what we found is that when you look at the tracer, you see the blue under the PIB-NC. That is totally a normal control. So in this type of radio agent, the tracer passes out of the brain and leaves the brain these cool blue colors if there is no amyloid present. But look at the middle row. You will see that this is an amyloid positive normal control. And notice the oranges and yellows that are present there similar to the one on the right, which is actually a patient with Alzheimer's disease. And so what you can see is that there's a group of normal older individuals who are still cognitively operating normally and functioning normally. These are our neighbors. They live next door to us. They have a burden of amyloid in the brain consistent with people with Alzheimer's disease. And what you can see from the scatter plots is that what we found, and this is not only at Harvard, but also at Mayo Clinic and at in Australia, in the ABLE study, that there are 30 to 33% of all normal older individuals who have a burden of amyloid consistent with AD. That was shocking. It shouldn't be shocking in the sense that pathology studies have said this for many years, that people die who are cognitively normal have this pathology. But this is the first time that we ever had the ability to see it in vivo. Next slide. And so what individuals have discovered is that there's probably a 15-year window between when this pathology is building in the brain and when you begin to have symptoms of this disease. So that leaves us with a 15-year window of opportunity that if we were going to treat this disease, that would be the time to treat it. When people are still cognitively normal, and if you can remove the pathology from the brain, could you prevent people from ever going on to experience the dementia? And that is exactly where the field is at right now. Next slide. In addition, just about a few years ago, 3 years ago, so to speak, David Chen and Mark Minton developed another radioisotope using PET that now attached to the tau tangles in the brain. So now we have the ability to image both the amyloid pathology and the tau pathology. Next slide. And in some work done by Keith Johnson, what you see at the top row of brains there are the amyloid PET scans, and the bottom row is the people with the tau PET scans. And what you see on the right in the cognitively normal individual is that there is a minimum amount of amyloid in that top scan, and then you can see a little bit of tracer in the entorhinal cortex. And we think that almost everybody in this room has a little bit of tau in the entorhinal cortex. But what is the issue when that tau begins to migrate? And in the middle scan, what you'll see is another cognitively normal individual who has an abundance of amyloid in the brain, looking at the top. And looking at the bottom, you see not only do they have tau in the entorhinal cortex, but you actually see it migrating into cortical regions of the brain. And we think that that is the threshold where people may begin to be developing symptoms. The third scan, of course, is someone who actually has AD dementia. Next slide. And in this slide, what we also notice, and I'll just walk you through it because there's no reason for you to remember this, is that we find that there's a correlation between the amount of amyloid in the brain, alcohol in the brain, that too. Yeah, the amount of amyloid in the brain and the amount of spreading of tau generation, so that the higher the amyloid burden, the greater the spreading of tau. Next slide. So where the field has gone, and this is my colleague Risa Sperling, who I've had the privilege and opportunity to work with for over 20 years. She led a work group led by the NIA and the Alzheimer's Association to define this 15-year preclinical period of Alzheimer's disease. And this is research criteria because given the fact that we have these biomarkers now, we know that some of these biomarkers begin to move earlier than others. And what you see in the graph here are these jack curves that if any of you are in the Alzheimer field have seen this slide a million times. But what we know is that amyloid begins to migrate. Tau is beginning to migrate under the surface and also begins to migrate up. There's probably a plateau of the amount of pathology, so it's not like as if you get so much of it that it falls out your ears. You know, it does plateau out. And what's interesting is that at the line by the green, that's when cognition begins to change. So these biomarkers are beginning to move in individuals long before cognition begins to change. And my role as a neuropsychologist in this field has been to try to move that curve over to the beginning, because we need to find sensitive tests that are not as expensive as a PET scan, which costs about $7,000 to do, to be able to detect those who may have the burden and are at risk using cognitive measures. So some of the tests that you folks are familiar with won't work in this population, and I'll show you a couple of them that we've been working on. What we, go back, just excuse us. No, thank you, you're doing a great job. Better than I was. So what we know is that there are stages to this preclinical disease, and what you'll see in the blue arrows there is that the stage 1 is actually people who have amyloid and nothing else. Now, what we don't know is, can you stay with a lot of amyloid in your brain and not migrate into neurodegeneration? We don't really know that yet. The second stage is people who have the amyloid plus the neurodegeneration. And the third stage is the people who have the amyloid plus the neurodegeneration, and they're beginning to notice a change. So these are the people who have subjective cognitive concerns or complaints, and they may also begin to show minor changes on cognitive testing that are particularly challenging. But in addition, we also know there's a group of people who have, tau neurodegeneration without any amyloid at all, and we call those people the SNAP people. And we'll talk a little bit about what happens to them in a little bit. Next slide. Thank you. So now when we talk about treatment, and this is what you guys are really interested in, right now the only treatments that the FDA has approved are symptomatic treatments, not disease modifying. And in these symptomatic treatments that you see advertised on the TV all the time, Aricept, Raminol, the patch, Memantine, they're only symptomatic medications. They do nothing to stop the disease process. They may stall the disease a little bit, maybe for a couple of weeks. Some people with high cognitive reserve may experience a little stability for maybe a year, maybe 2 years, but it's doing nothing to the actual progression of the disease. So next pointer. So what we want to have are disease-modifying treatments. And the hope is that if you were able to interfere and remove amyloid or tau from the brain, could you stabilize that curve so that it never goes down to the progression of a dementing syndrome? Next slide. So where we're at in the field is in secondary prevention trials. Now, what a secondary prevention trial is those that have the disease. So, and the way that we know how to identify these people is through PET scans. So these are people who have a burden of amyloid in the brain. And we then put them into a treatment versus placebo, because we don't know if it's going to work or not. So it's still placebo-controlled trials. And we see whether or not removing or interfering with the disease process can actually stall the progression of the disease. Now, we'd all like primary prevention. This is what we have in this country for tooth decay. You know, every city in this town puts chlorine in the water in order to prevent tooth decay. And that's what we call primary prevention. We would love something like that for Alzheimer's disease, and maybe we'll get there, we don't know. Next slide. So what are the treatments that we actually currently have for prevention? Now, you know that, I assume many of you know, that Alzheimer's disease does have a familial form of the disease. These are people who have a genetic mutation, either presenilin 1, presenilin 2, or on the APP gene. These are the people who have this mutation who will go on to develop the disease. If you don't have the gene, you won't go on. And some of you may have seen the 60 Minutes production of the Colombian family, who the entire people in this town, followed by Dr. Lopero, get the disease. And so one of the things that they're doing is a treatment trial for those who have genetic risk versus those who don't, and see if they can eradicate the disease in that family. But in this country, 1 to 2% also have a familial form of Alzheimer's disease. And that's what we have called the Dominantly Inherited Alzheimer Network Treatment Intervention Trial. And they're beginning to do prevention trials in that population, as well as in the people who have a genetic risk on the apolipoprotein E gene. And these are people, if you have the 4 allele, you are the most at risk. Now, this allele does not cause Alzheimer's disease. It just puts you at risk for the disease. But what they are trying to do is, because the disease begins to manifest cognitive changes earlier than late onset, so in your 50s or early 60s, they're beginning to treat these individuals as well. And the one that I've been involved in, and potentially the architect of the cognitive outcome measures of this, is the A4 trial. And this is where people, by virtue of age, go on to get the disease. And every decade, the percentages or odds of getting the disease increase, so that by the time that you're 80 years of age, you have at least a 40% chance of having Alzheimer's disease. And so we want to treat those people as well while they're still asymptomatic. Next slide. And then one of the trials that, so the A4 trial, which is the one my husband is in, thanks be to God, is closed to enrollment. And one that's currently open now is the early trial. And again, these are people ages 60 to 85, because when we were recruiting for A4, there were a number of people who were 60, 61, 62. How come I can't get into a trial? So we decided to reduce the age range and particularly increase the earlier ages with those who are at risk. And so that trial is currently enrolling. And what they're doing with this particular trial is not a drug to remove amyloid from the brain, solanezumab, like they're using in A4, but rather they're using a BACE inhibitor. And that inhibitor prevents amyloid from being developed. And so they think if they get it early enough, they'll be able to stop the production of amyloid that is deleterious to this disease. The next one that's currently funded by the NIA but still in development is what we call the anti-amyloid prevention trial. And these are people who flunked out of the A4. So what happened is that people screened into the trial, but they didn't have a burden of amyloid in their brain. And so what we want to do is to take the people who have the intermediate levels of amyloid in the brain and put them into a treatment trial as well. Now the question remains, will this work? I pray to God every night it does. It's unclear, but what I do know from these trials, which are somewhat primitive and complex, is that we'll learn a lot from them and be able to make even better prevention trials. So the question that I was faced with in these early enhancements is, how do you develop a primary cognitive outcome measure in people who are normal? You know, it's easy to do it for someone who has a disease, so then you can say, well, you know, they're going to decline. But these people are all normal. How are you going to develop one of those outcome measures that may actually demonstrate a treatment effect? So, next slide. So one of the things we did in the Alzheimer world is we took observational trials and we looked at the people who progressed from normal to MCI, and then we went back and looked at the cognitive tests that were changing initially. And what we found in this work that we did with Mike Donahue in the observational trials of ADNI, ABLE, and the PI prevention trial was that if you made a composite of tests of episodic memory, timed executive tests, and global cognition, you may be able to capture the types of very early changes that people may be experiencing. Because one of the things I was worried about if you're developing a test for normals is how do you know what cognitive domain changes in each individual in this disease? Do some people have changes in executive function and not memory, or memory and not executive function? And how do you separate that out from the normal aging process? It's not an easy solution, but we think that in developing a composite of these various different domains, we may be able to get at that easier. Next slide. So some of the work that we've been doing in the Harvard Aging Brain Study is look at cognitive composites to see how they actually operate in people who have amyloid positivity versus people who don't. Now, the Harvard Aging Brain Study, of which I am the clinical lead, is a observational study of 300 plus normal, older, community-dwelling individuals. They're all volunteers, and they agreed to do cognitive tests on an annual basis, both the tests that are standardized as well as some more innovative, novel tests that we're actually experimenting with to see how sensitive they are to amyloid burden. And they also agreed to undergo MRI scans, amyloid PET imaging, tau PET imaging, and ApoE testing. So these normal volunteers are our lifeblood here for trying to understand how to develop prevention trials. And the Harvard Aging Brain Study participants have really helped us move the field toward prevention. And what you see in the work by Beth Mormino here is that it was the people who were in stage 2. Those are the people who had the amyloid plus the neurodegeneration that showed the steepest decline. What's of interest, though, which I think is important for prevention trials, is that the people who were in stage 1, who had amyloid alone, were not declining. And that's important if we think about prevention and removing amyloid from the brain in people with stage 1, would they not decline at all? And that, of course, is our hope. You can see in the dotted line, the third line going up this way, those are the SNAP people. Those are the people who have tau neurodegeneration only, and they don't decline either. And there's been 7- and 8-year follow-up in the ABLE study that shows that people with tau neurodegeneration aren't on the progressive track for AD. Next slide. So what we did is we took the primary Alzheimer cognitive composite that we put in A4, and we began to look and see how it actually performed. And thanks be to God, the amyloid positive individuals actually declined on the primary Alzheimer cognitive composite. When we looked at the individual tests themselves to see which tests were actually the most sensitive to that decline, most of them were, except for logical memory, which is the Anna Thompson story. And if any of you are in AD research, you know that everybody's known about Anna Thompson from South Boston for years, and a lot of people have heard the story. But what you'll notice in the red line is that the amyloid positives still don't come back. They don't have the same practice effect that the people who don't have amyloid in their brain. Next slide. And then the other important point here is we did a progressor analysis. And now what that means is that these are the people who literally progressed from normal to having very mild functional changes. That's like a CDR of 0.5. And we now looked at amyloid positive and negative. And what we found is that the people who declined were the people who actually had the functional changes as well. So again, it's the progressors in the disease who are actually showing the most decline. Now, I want to remind you that even though there's some functional decline, these are all still clinically normal individuals. Next slide. And we also looked at the effect of subjective complaints. As clinicians, we've always learned that if people come complaining about their memory, they're usually the worried well. And frequently that label has been put on women, generally during menopausal changes, because we all worry about our memories at that stage. And there is some evidence to show that those hormonal fluctuations that women go through can have an impact on memory. But it doesn't necessarily mean you have Alzheimer's disease. But if you have a risk for that disease, you then begin to worry that, oh my God, I'm acting just like my mom, you know? And that brings people into the clinic. So one of the things that we decided to explore in the Harvard Aging Brain Study was to see whether or not these complaints were associated with amyloid burden. And what we found is that yes, they are, but the ones that had the greatest complaints were the people who literally had both amyloid and neurodegeneration going on with them. So they had some real complaints. And sometimes they notice, but nobody else does, because a lot of people, at least in this study, have very high cognitive reserve. They're smart people, so that their cognitive reserve really keeps them from displaying some of the symptoms that they themselves experience because they're very aware of themselves. Next slide. So then what Rebecca Amarillo did is she looked at longitudinally to see what happened to these people over time when they complained. And she found that both those with amyloid in stage 1 and in stage 2 had similar complaints when you look longitudinally. But what was very interesting about this is that amyloid positivity was still related to the amount of complaints, but that the people in stage 1 did not decline. The people in stage 2 did. So again, in this preclinical phase, stage 2, those who have amyloid plus neurodegeneration begin to show the greatest decline and change. So if you had a treatment trial that actually targeted amyloidosis and you got it before neurodegeneration, there is some hope that maybe or not we could eliminate these declines that we're seeing in the studies. Next slide. So the other thing that I've been working on is seeing whether or not you could do some of this stuff at home. So one of the exploratory outcome measures of A4 was putting cognitive tests on an iPad. Now you have to remember this was like 2010 when we had this idea. Believe it or not, that's when the iPads were new. It's hard to believe because everybody has an iPad nowadays. And we wanted to see if we could literally put some tests of episodic memory, so that's my face name test that you see down there, along with a pattern separation memory task, and then tests of more reaction time and working memory kinds of tasks. So we partnered with Cogstate and we put these tests on the iPad. And that's the outcome of what that's going to be like in the A4 study is still closed yet. We don't have that data. But one of the things I wanted to explore is, could we do this stuff at home? And what I did is I sent iPads home with people. Thanks be to God, they all brought them back. But what we found is that even 80-year-olds were able to do this at home on their own, and it paved the way for this more novel use of technology for possibly doing cognitive tests. Because if you could get more than just once a year or once every 3 months when they come to the clinic to measure their cognition, and you got it every week or every month instead of every 3 months or every year, maybe we could see some greater sensitivity to change over time. And so that's where the field is moving, and I'll be participating in a technology conference at NIA talking about these various measures, even on the smartphone, you know, where even a lot of older individuals have a smartphone now, and what kinds of measures could we use that would be sensitive for this type of novel clinical trial work. Next slide. And the thing that I am the most excited about is what I call the digital pen. Now, click. So that looks like a pen, right? Click on, next slide. What happens is that at the tip of the point, there's a camera. Next slide. And what the camera is doing is measuring every nuance of your thought when you go to do a task. So for instance, if you are going to draw a clock, it will measure how long it takes you to draw the circle, the spaces at which you make the numbers, the confusion that you have of setting the hands, and it just allows you to look inside the brain as to how someone is actually processing information. So I've been working with some artificial intelligence professors at MIT, and through machine learning, we've been able to extract what we think are sensitive variables to the clock test. And the slide you don't have in your handout, next slide, is the new data that we just came off the press. And what we found is that the digital pen data, which you see as the DCT score, actually does much better than all the other kinds of standardized tests. And the digital pen data is sensitive to amyloid deposition throughout the brain, as well as to inferior temporal tau. Now, we're still analyzing this data, but it really will revolutionize the field in being able to have sensitive measures that may be useful at the preclinical stage. Next slide. So I wanted to end this talk by, because this will be a question that comes up, how do you tell the difference between normal aging and early signs of AD, particularly now when the bar is high of trying to get people into prevention trials? How do you know? Next slide. So how many here have problems remembering who that movie star is, finding that word, what they went into a room for, they have to backtrack. Where did I park the car? Where did I put my keys? Can't find my hotel room. Disney helped us for remembering where our keys are. But all that, relax, is a part of normal aging, okay? Whew. So when do you worry? And I love this quote. I love the guy's name, Sir Norman Wisdom. I don't even know if it's real, actually. As you get older, 3 things happen. The first is your memory goes, and then I can't remember the other 2. Next slide. But what is memory loss? You know, since I've had to live up close and personal with it, I've finally become an expert in being able to tell normal aging from early signs of AD. And memory loss is not just forgetfulness. It's actually when something happens and they have absolutely no recollection. So our son gave us a camera for Christmas. And he went on and on about how wonderful this camera was. You could go under the water and take pictures, like we were going to do that. We are not 20 years old anymore. And we actually took it on vacation with us. We took pictures, we got used to it, we took the pictures off. And a couple months later, my son says, "Hey, Dad, can I borrow the camera I gave you for Christmas?" And he said, "Mike, you never gave us a camera for Christmas." Now, it's that kind of event, you know, and I could give you 100 of these types of examples where there's absolutely no recollection that something happened. And that's the kind of thing that you want to worry about. Problems with language, it's not just coming up with a word. People who have real language deficits have problems substituting words, saying one thing for another, or they lose the pragmatics of conversation. Well, they'll interrupt, although if you're from Boston, that's normal. They lose the social nuances of language that are really important. And so those are the kinds of things you want to look for. Getting lost or disoriented in familiar places. When you can't get to the mall anymore and you've gone there frequently, that's a problem. And so as family members and spouses, as granddaughters and grandsons, if these kinds of things are happening to older people, that's when you want to worry. Misplacing things. These are like important things that you put somewhere in order to find them, and then you can't find them. And another very important key is the loss of initiative. That is, people who no longer have the same interest in golf, for instance, and they were avid golfers, or, and they begin to want to just sit at home. Now, some of that has to do with the embarrassment they feel about their symptoms, but it's also a part of the disease process itself. Final slide. So those things are the things you should worry about, but there are also things that you can do to prevent. And these are non-pharmacological things. Physical exercise. We get a lot of that walking around this convention center trying to find the rooms from our casitas. The Mediterranean diet, or the MIND diet, as we mentioned, is really important. Social support, reducing stress, engaging in intellectual activity. Now, one of the things I do admire my husband for doing is that BU has this evergreen program, and for $200 you can take a graduate course that normally costs about $4,000 to $5,000, and he goes and he takes IT courses once a week. He doesn't always understand the material. Most often he can't do the homework, but he's doing it. Do you know what I mean? He's trying, and he gets to talk to the guys because he can't talk about that stuff with me. I don't quite understand it. And that's the kind of stuff you want to do. Don't recommend luminosity or some of these things that the FCC actually fined them several $1 million because of fraudulent advertising. These cognitive training things won't prevent dementia. And the other important thing besides regular checkups is sleep. Amyloid actually comes out of the brain or is removed from the brain during sleep. And it's important that we get good sleep. And now that for the last 10 years, medicine has been very important in sleep. So we want to make sure we do that. Last slide. So, whoops. There we go. So there's a lot to learn. I always like, this is a slide that Risa Sperling uses, that we're just the tip of the iceberg in trying to understand this disease. And there's so much that we don't know. Next slide. But what we're getting there. And I just want to thank you very much for your attention and for all the hard work you're doing to help us find a cure for Alzheimer's disease in our lifetime. Thank you.
So we have a couple minutes for questions. If anyone has a question, there's microphone. So I feel a little bit better because I really couldn't find my hotel room, and so thank you. That's really comforting. I had just been there like an hour before I went to work out, and then I worked out, and then I couldn't remember where my room was. I was on the wrong floor too. That didn't help. So
doesn't help.
No. One of the things that came up as we were talking about this, so what's the difference between dementia and Alzheimer's?
Yeah, that's one of the most common questions I get asked. Dementia is actually the umbrella term that refers to various pathologies that create changes in cognition and functional behavior. So what a dementia really means is that you have literally changes in your cognition and function from baseline. Now, Alzheimer's disease is one pathology that causes a dementia. Vascular disease is another one. Lewy body disease is another one. Parkinson's disease is another one. And you can go on like that with various different pathologies that cause a dementing syndrome. I do have to say that the pathology literature says there's very rarely do people have pure Alzheimer's. They frequently have a combination of vascular disease and Alzheimer's disease together.
Doctor, is it on?
Yes.
Yeah, thank you very much for your talk. My background is in exercise physiology, and you mentioned two things that caught my eye, and I'm just curious. For people that live to 100 years plus, one of the items said in your 70s it's okay to be overweight. I always thought that your body mass index, which I don't agree with necessarily, because body mass can be fat weight as well as a lean body mass. And again, one of the other things I've found for older people is if they engage in light weight training, it is very important for bone mass maintenance as well as strength development, which would not result in falls.
Right.
And the second thing, my other question
He's
was...
testing my memory that I'm going to hold on to this.
Yeah, well, that's what I'm testing. I'm doing a test of your status, but I'm joking. And then what is older? I always feel when people ask me my age, I always like to kid with them, but I'm serious. I tell them my physiological age, at least what I feel. I try and eat right, exercise regularly, and again, I'm grateful my early education was in health and physical education. My master's was in exercise physiology. I became a nurse. I mixed everything together, and I really see the need, and it's sad in this country that physical education is removed from schools. We're seeing a high obesity rate in children, and with that, concomitant coronary disease and other processes that are just negative for the body. Thank you.
Oh, those are excellent comments, really. I don't know what old is, because as I get older every decade, that becomes young. But normally we say 65 years of age and older. The oldest old is generally 90s and 100s. And those people who do exercise, even slow types of exercise is really important. The obesity part, it's not just obese, you're overweight, so you're not really obese. But why they associate that with better longevity in contrast to Alzheimer's disease is because the people with Alzheimer's disease lose weight. And when in your 70s, you're starting to lose weight instead of gaining it or maintaining, that becomes a symptom of the disease itself. You're also losing smell, you're losing your ability to taste. I mean, there are many confounding factors. So, thank you.
Thank you.